Hi everyone. Welcome to day 3 of Clear Week. And this Clear session, mental health new roles and models of care to improve access and free up clinical time. There's a few things, just like the housekeeping, that we placed in the chat just so you're aware. This session will be recorded, so feel free to keep your cameras on or off. And please also, can you just make sure you stay on mute whilst the presentation is taking place? And any questions you may have, feel free to pop them in the chat or place your virtual hand up. That would be great. And our speakers today are Annabelle, Mandy, and Deirdre, who I will pass on to, and they can introduce themselves and present. So over to you guys.
Thanks, Suman. So my name's Annabelle Beasley. I'm a Clear delivery lead, and I focus on mental health projects. I'll introduce Mandy and Deirdre later when we actually get to their presentations. But if you could go on to the next slide, please, Suman. So I'm just going to give a quick introduction to Clear for people who aren't aware of it, and then a brief overview of the mental health projects that Mandy and Deirdre took part in. And then I'm going to pass over to them because it will be much more interesting to hear from them than me. So CLEAR stands for clinically-led workforce and activity redesign, and it is predominantly an education programme for clinicians, but they work on a live project during that programme. And it has 4 stages, as you can see on the screen. So the clinical engagement phase is to do with qualitative engagement, and the project teams will go out and about and talk to people on the ground to find out what their views are on the services that they're looking at, to get that lived experience. And then they will do some quantitative data analysis using some lovely dashboards that our data team developed for them, and come up with some key challenges from triangulating both of those key bits of data. They then innovate, and this is the bit that I like the most. Not all of our participants did, but I think it's the funnest part. This is where we come up with lots of different ideas about how to develop new models of care and think about the workforce that they've got and how to redesign that to deliver improved services. And then they will present these to the board at the end in form of recommendations. Next slide, please. So we have worked in various places across the country, as you can see from this map. We've done over 40 projects now in lots of different clinical areas, including urgent emergency care, anticipatory care and ophthalmology, and obviously mental health. And next slide, please. So we did our first round of mental health projects they started in the summer of 2021. We had 6 sites across the country, as you can see from the map. And the projects were in a variety of different areas, including community mental health teams, perinatal, improving access to psychological therapies, and inpatients. So some of the recommendations that they came up with were to either do with, developing sort of new pathways to improve efficiency or to reduce waiting times. They were to improve access to the services or to develop new roles altogether. We tried to get people to think about the impact of the recommendations that they are making. And the boxes along the bottom have got a bit more information on that. Some of them have looked at kind of time savings and tried to sort of form a cost from that. And others, like the inpatient one in the bottom right, looked at kind of reduction in bed days and readmissions and figuring out the cost savings from that as well. Next slide, please. I think I might actually be passing on to Deirdre, who I'm really excited to hear from. So we finished these projects about a year ago. And so Deirdre and Mandy are going to talk to us about, what they did, but also what's happened since, which I'm really interested to hear from you guys. So over to you, Deirdre.
Yeah, hi, I'm Deirdre. I'm a clinical psychologist from Norfolk and Suffolk Foundation Trust. Next slide, please. So our focus was improving service user journey in the CMHTs. We realised that service user journey was delayed through the CMHTs, that we weren't engaging people and bringing them into treatment or active intervention quickly enough, and we weren't discharging them quickly enough. So there were 3 clinicians leading the analysis. That was myself, one of our matrons, Catherine Roper-Deleek, and one of our consultant psychologists, Caroline Methuen, and we conducted 22 interviews with staff across 5 CMHTs. And we also had the so the 33N staff conduct some focus groups with us, with some service users and carers as well, about service user journey. And those 5 teams cover a population of around about 414,000 people, and we have about 2,600 patients across those 5 teams. So it's a kind of large clinical area that we were looking at. The challenges that were identified mainly through the qualitative data was that there were some problem cohorts of patients identified. Some of these problem cohorts were the hard to discharge, and some of them were the hard to engage clients, and both had slowed journeys through the CMHT. The waits for psychological intervention and consultation was slowing the service user journey down. So the waits were a service user arrives in the team, they are assessed, and then there was a wait for any kind of assessment or consultation that might lead to deciding what psychological treatment might be appropriate. Staff morale at the time was at an all-time low. It has since improved, I'm glad to say, and retention was poor. Caseloads were extremely high. So it's a CMHT, so we see sort of complex and severe mental illness, and some of the care coordinators had caseloads of 60 at that time. We've now reduced that to caseloads of 35, which is a bit more manageable. The high caseloads dictated their work, so it was just generally about monitoring and support rather than providing any active intervention at the time. And some of those care codes were extremely frustrated that they couldn't provide the active intervention or the quality of care that they wanted to provide. The GPs, some of our GPs were re-referring almost immediately on discharge as well. And we did have the start of our primary care networks around this time as well, which included mainly qualified nurses in primary care, mental health practitioner roles, but they were not taking step downs from the team at the time. And poor communication with GPs was present around CMHT thresholds and roles. So we spent a lot of time processing referrals that weren't appropriate for the CMHT with no benefit to the patient. And then the last thing was that CMHT service users were excluded from other services where they could be waiting in parallel for something, like waiting for psychological therapy in the CMHT, waiting for an ASD assessment. These were needing to be done sequentially, so that was identified as a big problem as well. Okay, next slide, please. Yes, we had loads of different ideas, but they came in 3 groups. So one was about sort of internal changes and what we call tweaks to processes. And then we had major changes, which would be entirely new models of care. And then we had some trust-wide solutions, mainly on the idea of staff retention, actually. I'm only going to focus in on 3 of the ideas, but I've just given you them all in case you want to have a look at what the content was there. So we'll present 3 ideas in the next slide. Yeah. Oh, 4 ideas. Okay, so discharge clinics. So we decided that care codes, because they were very time poor and didn't have that reflection time, needed some additional help to get people to the point of discharge. So we were going to put in discharge clinics. I'll talk about what happened instead of that, but we were going to put in discharge clinics where people could bring along patients that they were struggling to discharge, and we could work together in consultation to help them formulate and execute a safe discharge. We developed ideas around an engagement pathway, so that instead of letting service users drift in their pattern of not contacting us or with behaviours that were engagement impairing, we would actually actively formulate with the service user what these barriers to engagement were and try and work together on those barriers to engagement. We wanted closer working with our primary care networks to ensure safe and successful discharge and step down. And we suggested a psychology, because we were working virtually by this stage, a real-time drop-in for consultation appointments, so that if we're available, our colleagues are out on a home visit or they've got someone in with them, they can call us in on online for consultation. So they were the ideas that we generated. Next slide, sorry. Yeah. So we didn't actually get the discharge clinics. We had just started setting those up, but instead we generated a business plan and we got 3 new clinical nurse specialists to help other staff with their discharges. So it's not a clinic, but it is a resource and it's there for each team and they can consult with it. And it has reduced team caseloads by employing these clinical nurse specialists. We are getting more throughput. In terms of the engagement pathway, this is still under development, but we've now got a Getting Ready for Change workshop, and we've got a Getting Ready for Change supported psychoeducation workbook. So that's a kind of workbook that staff members can use over several sessions to identify what barriers to change are with a service user. And it helps us really understand what the motivational and sometimes relational barriers to change are. And we're also trying to create some posts so that service users, there are cohorts identified that we don't do well with, and they're the usual things. It's people who are very chaotic and are using large amounts of substances as one group. We've got other groups that we've identified that we're not reaching, but we've created a new psychology post in what's called the ADDA project, which is a project supporting people who have issues with substance misuse and have had contact with the criminal justice system as well. So what that means is they can have a more flexible model where they meet our patients on a site where they're already presenting, for example, to get their script, and they can just drop in a bit and they can engage them there. That stops the cycle of sending out appointments, them not turning up, and us then labeling them as non-engaging and discharging them back to the GP. So that's been a really successful post. It's making us think of more posts like that to improve engagement with our hard to reach service users. In terms of successful step down, we've been working really actively on that, and now our PCN MHPs are routinely involved in step down and indeed in triage to the service. So we're trying to stop GPs from just re-referring when a service user presents by having the mental health practitioner who's based at the surgery involved in that discussion when someone's referred into the team, and seeing whether there's something else that we can do instead. And unfortunately, the Psychology Live idea, which was the virtual call us into an appointment situation, was shelved because the psychology team were under huge pressure. But what we have done is offered extra assessment capacity to triage and front door. So that's at the front end of the team, and also to anyone who's on our CMHT managed waiting list. So we're trying to get earlier in that way instead. So the ideas were all incorporated, but in a modified form. Okay, next slide, please. Yeah, so the ideas generated have a lot of longevity, so they're living on beyond the CLEAR project. So I put all the ideas up because many of them are ideas that we're taking forward to the development of our primary care networks and also our personality disorder complex emotional needs pathway as well. So one of the ideas we had was using peer support workers in a recovery dyad alongside therapy, so that people were getting help engaging in stuff that was socially beneficial and meaningful for them alongside their therapy, and that will be there, but will be transferred into the primary care network. Staff found it extremely validating that their experiences were treated as hard data. They liked that idea. It was now qualitative data rather than just a rant, or staff had real concerns about being perceived as troublemaking or feeling dismissed when they brought things individually. So we were presenting the data collectively as data was really useful. And actually senior management listened more to that, and so did the trust executive. It was seen as data, so that was useful. It created a focus on the skills needed rather than us getting trapped in conversations about roles and establishment workforce. So we actually looked at what skills were needed to do the tasks that we'd identified weren't being done. That brought new roles to the team, particularly the nurse consultants and clinical nurse specialists. It's also highlighted the need for OT. We don't have much OT in our team, but much of the stuff that we've done around the engagement pathway and also around recovery dyads has when we've presented this to our OT colleagues, they say that's OT, and we've agreed, we need more OT thinking in our clinical secondary care space. We found it really hard. If you're doing this as well, you'll find it really hard to get the quantitative data we needed from the NHS mental health service data set. So we've had to go away and do subsequent qualitative and quantitative analyses on the back of some of the hypotheses that the CLEAR project turned up. And I'm working with our quality improvement lead, because I think a lot of the things that come up out of the CLEAR project, the recommendations, they're really hard to implement and see a change in the time frame for the CLEAR project, but they could be yoked to quality improvement projects. So quality improvement projects have a specific methodology where you monitor, you put in a change and you monitor what the change is in a quantitative way. So you have a baseline, you put in a change, you look at whether there is any change in the data. And we think that if we can yoke those two things together, that will be a really effective way of monitoring the impact of innovation. So we're still working on that at the moment. And that's it. That's where we've got to.
Thanks, Deirdre. That's really really interesting. Has anybody got any questions they'd like to ask now? If so, put your hand up. Ooh, Toby, go for it.
Thanks, Hannibal. Thanks, Deirdre. It was really interesting. And this question is asked selfishly because I'm working on a mental health project at the moment. Just to drill into a little bit more about, you mentioned the limitations of the MHSDS data set. Was that limitations with the data itself, with the extraction? Could you just give me a tiny bit more detail around that? Because I'm really interested to know about that.
Two problems. One was the data completion. So we looked at things like diagnosis, and I think that depending on which service area it was, 10% completion rate was quite common, And then we looked at the difference, because we were questioning that. We looked at who's putting the data in, and it wasn't, as you might expect it to happen, on the basis of a psychiatric review. It was an admin assistant putting that in at the point that the referral landed. So it wasn't a bona fide diagnostic thing. It was kind of best guess. So there were all kinds of problems with data quality. The extraction was the interface that CLEAR provided was, we could see the potential benefit of it, just that we couldn't pull off the data that we needed. So we wanted to have things like number of inpatient admissions that our service users had over a period of time. That wasn't possible, because in the way our trust enters the data, each episode of care is treated entirely differently by the data set. So we can't aggregate across episodes of care. So that was really problematic as well.
And that's where the qualitative, I mean, at least that's sort of where the qualitative can offset that. And like Annabelle says, that kind of triangulation can at least in some way mitigate against those. But I guess there's always caveats that you have to make with data. Data will only tell you so much, I guess. So no, it's really interesting. Thank you.
You're welcome.
Thanks, Toby. If there's no more questions right now, we can have a bit of a Q&A at the end as well. So if there's anything you want to think about and raise, then let's do that. And I'm going to introduce you to Mandy now. Mandy, over to you.
Thank you. So hi, I'm Mandy Shannon. I'm head of workforce redesign and development at Midlands Partnership Foundation Trust. That wasn't my job role when I started in CLEAR. I'm an OT by clinical background and was working as an AHP professional lead and working clinically as an OT in perinatal. But since the CLEAR project, things have moved on a little bit, and I have a new role now. But what I'm going to talk to you a bit about is the project that we did at the same time as Deirdre's as well, which was looking at a community mental health team. So can I have the next slide, please? So in terms of our project, we looked at creating some efficiencies through changing the skill mix via actually shifting some of the tasks and thinking about different roles within the team. So very similar to what Deirdre was talking about, there was a team of 3 of us as clinicians, myself giving that OT sort of perspective, working alongside Fiona Preston, who is a dietitian by background, and Michaela Kemp, who is an advanced clinical practitioner. So we were the 3 clinicians within the trust leading on this. And our staff engagement was with 20 staff, and that was across 2 community mental health teams, and included a range of different staff as part of that, including the admin staff and the operational team leads as well. You can see a little bit of information there about sort of like the number of referrals we were talking about and the number of contacts that we looked at as part of it. And the whole trust covers a population of 1.5 million, but obviously this project we didn't engage with all of those. But so in terms of the challenges, what we found when we started talking to people, that they were talking about needing an increase in number of staff as part of the team. They felt very fatigued. They felt that the caseloads had increased, that had had an effect on their health and well-being, and the service that they were providing as part of that. And I think what we did was, through that engagement, we got a lot of information from staff and then put that together with the data as well. And what we found was that there was actually been an increase in complexity and acuity of the referrals that they were receiving into the team. And that was actually causing them to struggle in terms of providing a responsive service. Yes, caseloads were really high. We did the project alongside the community mental health transformation programme as well. So there were already changes that were happening within the team, but very much what they were finding was that there was an increase in time that clinicians were spending actually responding to unplanned activity, and that had particularly been since COVID. And they were finding that increase in complexity of service users was meaning that actually they needed to get in contact with the service on a more regular basis. And then what was, I suppose, a resulting sort of factor of that was then having an impact on planned care. So sessions that had been planned in to help people to move forward with their treatment were then potentially having to be cancelled as a result of trying to deal with some of the unplanned and perhaps more urgent situations that had happened during the day. We were also hearing about sort of like the impact on admin as well, and their stress levels. Quite often service users were phoning up wanting to speak to somebody fairly urgently. If somebody wasn't available because they were in planned activities, then actually sometimes those needs escalated, and quite often admin staff were trying to deal with that without the clinical experience to do that. And we saw from the data as well that there'd been an increase in cancellation of those planned activities, so that people could respond to the unplanned side of things. And that was leading to an increase in length of time that people needed to be involved with services, and interrupted the continuity of the interventions that were being offered. Staff as well were talking very much about having to employ a large range of different clinical skills throughout their working day, that was having an impact on their health and well-being as well, and as well as their sort of satisfaction at work, and ultimately on the retention in the team as well. Can I have the next slide? So we pulled together all of that information, triangulated that, and similar to what Deirdre was talking about, I really enjoyed the innovation stage of it. We came up with some, quite different ideas. I think not all were perhaps within the realms of possibility at that time, but the 3 recommendations that we put forward to the team was firstly to implement a responder role into the team, and that role was very much about managing that sort of unplanned activity and just exclusively doing that. So that was around having a qualified member of staff who would be there in terms of those mental health assessments, looking at that sort of current mental health needs, risk assessment, care planning, that side of things, but also with somebody with lived experience as well. So being able to offer some support from that lived experience point of view, being able to offer service users phoning up some of that in the moment coping strategies, being able to link that to the planned interventions that they were getting, and saying, do you remember when in the session we talked about using these coping skills? You know, let's talk through how could you use those in the situation that you're in at the moment. So the teams already had duty workers as part of that. They were already being recruited to, so the funding was already there for that. So those roles became part of that responder side of the service. And the teams were also looking at having some lived experience roles as well, being funded by the Community Transformation Fund side of things. So again, the funding got moved over to be part of this responder role side of things. So the other recommendation then really was that actually the planned intervention side of things, that we had an expansion of that there was more group work available. There were only a small number of groups being carried out at the time, and that actually some of the staff had those very specific intervention roles, and that they concentrated on providing that side of the interventions. And then the other recommendation that we put forward, which I think was again very much what's been talked about before, there were some challenges in terms of the data. We needed to do some cleansing of what was being inputted, so we could make sure that there was some consistency and some accuracy with those data outputs. So linking in very much with the teams that we'd already got in the trust to be able to look at that. And also sort of, you know, linking up as well, I think like Deirdre was saying, in terms of like the diagnostic side of things, making sure about the data that we were inputting, but also thinking about how do we capture that increase in complexity of cases was something that we really struggled with, and are still struggling with that to a certain extent as well. I think it's something, you know, in mental health that's quite difficult to be able to pull that data. So that's something that we're very much looking at the moment. So can I have the next slide, please? So in terms of what's happened since the project, we very much engaged with the teams as we went along. The teams were really keen on the idea of having these responder roles, to the extent where we actually had to say, please don't start quite yet. We're not quite at that stage. So they were very, very keen. And actually, by the time we went to the trust board to present, it had already started at that point. So we were there probably more to give information than to ask for their support with that. So the teams have very much taken those roles. They've run with them. They have they've shared, you know, and spread that across one side of the patch, and we're starting to look at our other geography now. So those roles have been recruited to. Part of that is using the transformation funding. So we're currently just looking at how can we make sure that those are funded moving into the future. Those roles are very much considered a really valuable part of the team. They're very much giving the team some stability for staff members, but also for our service users as well. There's definitely been an increase in that timely response. We've had some great feedback from service users in terms of actually having that in the moment. Let's think about what coping strategies, you know, you could be using. And people have found it very valuable that they've got people with lived experience that they can speak to. We're doing some signposting onto other services, so that might be for sort of finances or accommodation or that side of things. The teams are very much run with putting together some processes. They've made sure that they've got clarity of roles in the team, which was something that came up as part of the clinical engagement. People weren't always clear about the different roles within the team. Staff are talking about finding less stress and pressure during the day because they are able to carry on with their planned sessions, knowing, you know, that they come out of those, and actually anything that's happened during the day has been dealt with by the responder roles. Other teams are finding that role very helpful because they're able to link in and get that timely response as well as part of that. We've also heard about actually those roles opening up some career development opportunities as well. So we've had people who've gone on to apprenticeships as a result of having some of that experience. Staff have talked very much about really enjoying having the choice in how they use their skills. And that we have some staff members who really enjoy that, sort of build a rapid rapport and that unplanned sort of side of the work, and then actually those changing priorities and whatever. And then we have some staff who really enjoy that sort of planned intervention side of things. So staff have got a choice as to, you know, how they use their skills. And one of the things that we talked about during the project that they're just looking at is potentially having a roving sort of role as well, so that people could do 6 months doing one of the roles and then move over and spend some time doing the intervention side of things. So they're currently just sort of exploring what the appetite might be for looking at that as well. We have seen some further increases in acuity and complexity within the team. So I'm not going to sit here and say that it's sorted everything out for 1 minute, and caseloads are still quite high. But I think that obviously those roles have really helped to make sure that actually the service that's being provided has got that timely access to it. And that both the team and the service users are really feeling well supported as part of that. Can I have the next slide, please? So in terms of that sort of like learning and development as part of that, both myself and Fiona, the dietitian, we've both moved on to other career opportunities, working probably more from a workforce side of things, but very much taking our clinical experience and making sure that that is very much at the heart of all of the work that we're doing. We're still focusing on that staff engagement, making sure that staff are very involved, feeling that they've got a voice as part of that. So it's really opened up some opportunities for us. All three of us still use a variety of the different tools that we used. And that's particularly around sort of exploring some of that creativity, increasing innovation. That's been really helpful with the roles that we're in at the moment. We all still really focus on that skills side of things, not talking about the roles, and that very much forms part of workforce planning that we're looking at. And you know, we've used that in a variety of different ways, not just for clinical staff, but also looking at admin staff as well. I think it was very much around that sort of importance of triangulating that information. The staff engagement people talked about very much about we need more staff. And I suppose we had some worries that once we got to the data and actually that was showing that actually that wasn't necessarily what was needed. We were quite concerned about how the clinical staff would take that. But actually that triangulation and being able to go back to the teams with some root causes, they took that on board really well. And actually it really helped them to understand what was happening behind that, to then be able to look at the recommendations that we'd made. And I think really helped in terms of them thinking about taking that forwards. So I think that was something that was really important, getting to those root causes. and being able to present that in a way that the clinicians were able to take on board, and the data that supported that, evidence that, and helping around the funding side of things. So we have very much had, you know, some really positive responses to that clinician-led side of things. It's always sat very corporately for us. And actually having that clinician focus and very much having that engagement has been a really positive experience within the trust, and I think it's very much led to the role that I'm in now, which is about bringing that sort of clinical element into the workforce redesign and planning that we're doing moving forwards as a trust. I think that's my last slide.
Thanks.
Are there any
Mandy.
questions?
Thank you so much for that, Mandy. That was really, really great. And it's so good to hear, you know, what you've managed to input, and also your career development. That's fantastic. I do remember your colleagues really chomping at the bit even before we'd got to the recommendations fully, hadn't we?
Yeah.
And they were really keen to implement the ideas, weren't they? It was
They
it was
were.
great. Yeah.
We were still working it up, and they were
Yes.
definitely wanting to implement. And you know, fair play to them. They have taken, you know, those ideas, they've run with them, they've made them their own, and that was very much the way that we wanted it to be.
Yeah, definitely. Has anybody got any questions for either Mandy or Deirdre? Toby.
Me again, sorry. It's actually less of a question, just more of a kind of thought that's popped into my head. And again, it's just a thank you so much. This is a really interesting presentation, and I'm just thinking there are a lot of learnings on some of the current mental health projects that we're doing around teams who are facing similar pressures, who could really benefit from this approach. So I guess it's just thank you so much for that, because I really think we're going to take some of these learnings. We already would have, but to hear you flesh it out is so useful. So I think we'll be taking some of these learnings, particularly teams who sort of feel like they sit and have so many sort of different types of patient coming to them, and I won't name the site that we're working with for obvious reasons, but there is one who we are working with who just feel completely inundated, almost a dumping ground. And it's sort of some of these innovative approaches you're taking could be really used by them, I'm sure, in many ways. So I guess it was just a thank you, because it was a really useful insight. Thanks.
Thanks, Toby.
Yeah.
Caroline.
Yes, mine was just a quick question to Mandy with regards to having written up some of the case studies on the responder and intervention roles. Did I miss the responder roles have obviously been funded by transformation funding? What has happened to the other recommendation, the other roles?
So the intervention side of things, we already had those staff in the team. It was just that they were having to cover duty as well as part of that, and we're also trying to respond to people on their caseload that needed that input as well. So the team, in terms of sort of like the numbers, haven't massively changed. So we already had the intervention roles. The duty role has slightly sort of like morphed into more of a responder role. And like I say, we'd got some funding as part of the community mental health transformation, which had already been earmarked for some peer support worker roles. And we've used, you know, that funding and pulled those into those responder roles, as well as them taking on some other activities as well. So we will have to look at some ongoing funding for those roles in particular, but everything else was already there. It was about a different way of using those skills.
And overall, how has it gone down at the trust overall? Has it been?
It's been really positive, which is where I think we worked with across a couple of different mental health teams that took part in the staff engagement. But actually the other geography in terms of their community mental health teams, they've taken that forward as well. And we cover both Staffordshire and Shropshire. So we're currently having discussions in terms of the Shropshire side of things as well. and looking at their roles. I think some of their challenges are slightly different. We have some geography issues that come into that, so we probably won't do exactly the same over there, but again we're using the data, the staff engagement side of things, and some population health data as well, to be able to help us to think what would be most beneficial for those teams in the situation that they're in.
And Deirdre, that question to you as well, because obviously your trust has come back to do further projects. So they obviously, although not necessarily everything is implemented, they do feel it's beneficial.
Yeah, no, I think the methodology, because it isn't, it's kind of a quick and dirty methodology. It's actually really useful to get that qualitative. Develop your hypothesis qualitatively and then test it out quantitatively. And I like to work in a data-driven way, and I think the trust likes to see data before it implements change. So it does work really well. I think the missing piece of the puzzle for me is now yoking it to quality improvement projects where you can follow a change and the impact of that change over a longer time period. So so I'm in contact with our current sponsor, and we are thinking about how we, because also people looking for quality improvement projects all the time, we can provide them with projects which they could then investigate for us. So yeah, that's an exciting area for us.
And we're also doing very similar, where we're also looking at doing it as a collaborative sort of like approach and thinking about from that quality improvement side of things. I think it is very much supports that sort of implementation and monitoring of those projects. That's really interesting to hear.
Lovely, thank you.
Any more questions for Mandy or Deirdre? I've really enjoyed hearing about what's happened since. It's, we spent 9 months hanging out together, and so it's just really great to catch up and find out what you've been doing. And it's it's just so heartening to actually see that a lot of the recommendations have been taken forward in some form or another. So it's really brilliant to hear. Thank you very much for coming today. It's been fantastic. Thank you.